streptococcal glomerulonephritis and minimal change disease. So there are two patterns of injury that can occur in the glomerulus, the nephritic pattern and the nephrotic pattern, and different diseases can exhibit these patterns. Post-streptococcal glomerulonephritis is one we'll look at now that exhibits a nephritic pattern, while minimal change disease is one that exhibits a nephrotic pattern. But as you can see, there are other diseases that exhibit these patterns, and each can be distinguished by their features on different kinds of microscopy. For example, light microscopy, immunofluorescence, and electron microscopy. But let's start with minimal change disease. As I've said, this will result in a nephrotic pattern of injury. So what happens in minimal change disease isn't really understood, except that it's thought to be cytokine mediated. So there's some kind of stimulus to the immune system that leads to cytokines depositing or interacting with the glomerulus and causing a change in the glomerular filtration barrier. So as we've discussed previously, nephrotic syndromes all relate to changes in the glomerular filtration barrier, which is the three layers separating the luminal contents of the glomerular capillaries and the filtrate in the capsule. And so these three layers are, of course, the endothelium, the glomerular filtration, and the glomerular basement membrane, and the podocytes. And filtrate will be filtered through in this direction, and it will act like a sieve of sorts. And so what happens in minimal change disease is that this layer, the podocytes, changes. And whereas this represents a normal podocytes, the podocytes become very flat and less effective. And this is termed podocyte effacement. The rest of the glomerulus remains unchanged, as does the rest of the glomerular filtration barrier. And so let's take a look at how this will appear on different kinds of microscopy. So on light microscopy, if this was someone who was suffering from minimal change disease, there would be no difference between the appearance of their glomeruli and that of a normal glomeruli. You just have the glomerular capillaries, a normal amount of mesangium, clear Bowman's space, Bowman's capsule, and normal looking tubules. And there are no immune complexes deposited in the glomerulus, which is what immunofluorescence would show. That is to say, there's no antibodies depositing there. So you wouldn't see any changes on immunofluorescence there. There'd be nothing to see. But on electron microscopy, you'll be able to see this podocyte effacement. So if this is the capillary lumen here, this is a red blood cell, I believe. Here is a normal podocyte, and this is the glomerular filtration barrier cut across. And then where these arrows are pointing are showing areas of podocyte effacement, which are diagnostic for minimal change disease. So who gets minimal change disease? Children and adults, but more so children, and it can tend to follow an immune stimulation, perhaps an infection or a immunization. And clinically, unlike some other nephrotic syndromes which can lead to a wider range of problems, there's only albumin leakage in minimal change disease. So you would see edema, but you might not see immune compromise or hypercoagulability. And the response to steroids is really good, especially in children, and the prognosis is very good in children. So let's take a look at post-streptococcal glomerulonephritis, a different disease. This exhibits a nephritic pattern of injury. And so what happens here is that there's an infection somewhere, classically strep throat, that's the name, but it can happen with other pathogens and infections. And this infection brings about an immune response, and some of these immune complexes, these bits of antibody bound to pathogen, deposit in the glomerulus. And this triggers an acute inflammation due to immune complexes interacting with complement and then triggering acute inflammatory reaction. So on light microscopy, you'll see typical acute inflammatory changes, which we can describe as increased cellularity. So as you can see, this glomerulus, if we go back and look at the minimal change one, marked increase in what look like neutrophils and the cells of acute inflammation. Then on immunofluorescence, in this case we do have immune complexes being deposited. And with a lot of these diseases, they deposit in distinct patterns, and in PSGN it's described as diffuse granular appearance. So if this is the glomerulus, all the highlighted green areas are immune complexes. And then on electron microscopy, you can see something called subendothelial immune complex humps. So if this is the capillary lumen here, this is the subendothelial immune complex hump, and here is the glomerular filtration barrier here. And what this hump is made of is actually immune complexes. And so post-streptococcal glomerulonephritis tends to resolve in children, but can progress to the more serious, rapidly progressive glomerulonephritis in adults. And that completes the discussion on post-streptococcal glomerulonephritis and minimal change disease.